Perfect. There we go. All right, guys, let's get going. All right, so this is your 10 tips to help you nail the orthopedic audition rotation. If you guys don't know by now, this is an intramedullary nail for the tibia. I'm Gianni Ricci. I'm a PGY4, about to be a PGY5 at the Jack Houston Memorial Hospital in the Houston Clinic in Columbus, Georgia. All righty, so tip number 10. First thing you guys got to learn is be on time. Punctuality requires zero effort. I would arrive probably 10 minutes early to everything. It's important when you first start, especially your first day or your first week or your first time with an attending or resident, is to be on time. And if you don't know where you're going, you need to ask. And also allow yourself enough time for the unknown. Parking. Maybe you're not parking as close as you thought. Maybe your key card doesn't work. Maybe you thought you had the right office and you didn't. So allow for the unknown, especially when you first start. You want to be on time, especially, into that second or third week of your audition rotations. Be on time from a Warner report standpoint, from a surgical cases standpoint and clinic standpoint. If you don't know when you're starting, what's your start time for surgery? Say, oh, the first surgery is at 7 a.m. I guarantee you they don't show up at 7. They're probably there at 6, 6:15, depending on the attending. So ask, say, what time do you want me there in the morning? And have them give you a time and be on time. Number 9 is to be yourself. When you're on a rotation, our job is to kind of find out who you are and whether it's going to be this rotation is going to, or this program is going to be the right fit for you. So the last thing you want to do is lie to everybody and be someone you're not. This is why I included Dennis Rodman here. This guy was who he was. And that's the best advice I can give you whenever you're presenting yourself, is to be you. Don't try to change who you are, and don't try to be someone you're not. It helps you find a fit into a program. If you go to a place and you know what, you just don't fit in, it's not the program for you. Or vice versa, you go to a place and you're you and you're doing really well with the attendings and residents, that sounds like a good fit for you. You also come off more as a genuine person. You're able to kind of present your unique characteristics that are specific to you. Excuse me. It also gives you a human component. We're all human beings. We all want to connect with each other on a level, whether it's with orthopedics, or maybe we have something in common. Maybe you like to cook, maybe you like wine or something like that. Being yourself allows you to connect with other people, and I think that's also important. 8. So this is the orthopedic slide. Know the anatomy. So you guys are the masters of basic anatomy. You are the closest to the cadavers. You guys are closest to basic anatomy in medical school. So we consider you guys the masters of anatomy. So what are the most questions that we're going to ask you? We're going to ask you mostly about the anatomy. And how you can take it a step further is understanding the surgical approach and how do you apply that to basic anatomy. So what I would do is, if I'm with a resident and I'm getting ready for surgery the next day or the 2 days before, whatever, I'll just ask them. We'll go through the list and I would say, okay, what are you doing for this? Okay, I'm doing an anterior approach to the ankle. Okay, so I know that's the approach. So I have to know that anatomy for that approach. Okay, I'm doing a total hip. What approach do you use? Okay, I use the standard posterior approach to the hip. Okay, boom, I got to know that anatomy. And just speak with your resident. The resident should know the approach. The resident should know the approach going into the case. So just ask them. Even ask the attending. And then when you're studying your approaches, you want to look at intermuscular planes, internervous planes. That's all in ortho bullets. And also dangers. That's important. You want to look at things that can possibly hurt the patient. So you want to be aware of any neurovascular structures around the area, any specific tendons, ligaments, whatever it may be to stay away from. That's important for you to learn, and how you can, and that's how you can connect with your resident and your attending. And lastly, important structures and landmarks as we're going through. This here specifically in the slide to your right of your screen is the anterior approach to the ankle. It's the workhorse. And you got to know where it's in between, between tib-an and EHL. And under EHL, you have the deep perineal nerve and in the artery there. And that's important because you see it in surgery. So they're going to ask you when you're in surgery, oh, what's that? And if it's a tubular structure that's vascular, it has a lumen, well, now you know. So that's the major source of PIMP questions. And that's where I think really students can stand out, is knowing the anatomy. You can also focus your studying based off of that. So if I know the approach, that means I don't have to study the anatomy from the hip all the way down to the toe. I just know, hey, we're doing the anterior approach to the ankle. Make sure I learn that and make sure I understand that. So that's important. Number 7 is to be helpful hands. And the best question that you can ask on your rotation is, how can I help you? Whether it's to a patient, whether it's to an attending, or whether it's to a resident. We're never going to be annoyed. We're never going to get frustrated with somebody who just says, hey, how do I help? How can I help? What do I need to do? How can I help you? And I, I was kind of taught that when I was a fourth year, and it really helped me just be more helpful hands. And they'll tell you, you can help me by, before each surgery, having a marking pen ready for me so I can mark the limb. Okay, boom. Now I know for the next 3 weeks, I'll have marking pens in every single pocket in my jacket or whatever. You're there obviously to learn. I think that's the first thing. You're there to learn and expand your knowledge, but also too, you're there to make residents and attendings' lives a little bit easier. My goal leaving the audition rotation is to say, when I left, those guys said, oh man, I wish Gianni was here, man. He was a big help. That should be your goal, is from a helpful hands. Also, make sure you're anticipating steps when you're on call and rounds. If you're with a guy and you're doing total joints rounding on total joints, and on post-op day 1, they do a dressing change. What's the dressing? Okay, it's an island dressing or whatever. Just put them in your pocket. Anticipate that step, because you're going to go into a room. They're going to say, oh, we got a dressing change. Okay, I have it right here. Boom. It's perfect. When you're on call, as you start progressing, you understand what you need to do, from an example of reducing a distal radius. So when I was a student, I knew what we needed to do after, a couple audition rotations, and that was get the splint. So I had to get the splint ready, measure it out, have the web roll, have the ACE bandage. If they use the mini C-arm, get the mini C-arm in the room. Do whatever I could to set everything up, get the water. For the resident, to make his life easier when he's on call, he'll remember you, or she will remember you, for sure. And that's when I mean anticipate the steps. When you get a call, hey, we got a distal radius in room 11, just go to room 11, set it up, and that's anticipating the steps there. And then lastly, taking appropriate level of initiative. It's very good to take initiative when you're on rotation, but make sure it's the appropriate level. Don't overstep your boundary. Don't understep your boundary. You're the most junior member of your team, and that is important. All right, getting to that. Be willing to do the dirty work. And this is Oscar the Grouch here. My daughter loves Sesame Street. She's 15 months old. But remember, you are the most junior member of the team. Okay, so for example, in surgery, get the bed. I mean, that is like, you would be surprised how many kids or students don't do that. Go and get the bed for people. Help move the patient on and off the bed. And if you don't know how to do it, just ask. Hey, can you help me out? Can you show me how to use the roller, or can you show me how to safely do this? So for the next time and for the next rotation, they taught you. And they don't listen. We do not have a problem teaching people what to do, especially if they ask. So that's the first thing. In surgery, get the bed and help move the patient. Also, like I said before, dressing changes. Anticipate, we're creatures of habit. So we're going to use the same dressings over and over and over, and just have them on your person. It's just a lot easier. Find the closet, get the code, put them in your pocket, and have them available. Suture removals in clinic. Oh man, when I was in resident clinic, that's all I did as a med student. Sutures, and just go take them out. And it's just helpful. Also doing a surgical pre-scrub. So some patients, especially like on trauma with your attending, they take the scrub brush and they'll scrub down the limb, and they'll clean the limb before they do the formal sterile prep. I remember when I was at a rotation in York, Pennsylvania, and they would always do a pre-scrub. So I'd walk into the surgery room in trauma, and I had a white towel on my left shoulder, and I had 2 scrub brushes in my right hand. And I would just go in and just scrub the limb. Like, I knew that's what they did every single time, and they were appreciative of that, I think. And I think it helped move things along. And lastly, this is why I put that picture on. Don't take out the trash. Do whatever you can to help turn the room over and help the team out. Now, I'm not saying you got to grab a mop and clean the floor. I did that, and I think that was stupid. But taking the trash out just helps. Just little things like that. Don't be afraid to do the dirty work. You are the most junior member of the team, and I think they'll reward you if they see you doing that stuff. Number 5, be nice to everybody. And that includes ancillary staff, That includes, scrub techs, nurses, medical assistants, the people that serve you food at lunch and breakfast. I mean, you'd be surprised. And I'll tell you guys, some of the biggest named orthopedic surgeons that I've met so far. I mean, biggest names. I mean, they have pictures of themselves with, one of the cafeteria workers who gives them their cheeseburger every Friday. These guys, these people are nice to everybody. And it's important. I think you have to approach medicine as a team sport. Everybody's on your team. You're not better than anyone else, and they're not better than you. And by just being genuinely nice to people, they listen, and then still everybody's not going to be nice to you back, and that's fine. Okay. And I'm not saying go down there and just be nice to be nice, but you'd be surprised. You really would be surprised who goes to bat for you when you're not there. And I've seen ancillary staff people, I've seen nurses who've worked for surgeons for 20 years be like, you got to take that kid. That one you got to take, and they'll help you. The attendings and the residents notice that. It also is a direct reflection on how you treat your colleagues. So when you're a resident, how are you going to treat the people that work with you every day? And that's important, because I'm going to tell you right now, orthopedics is a team sport, medicine's a team sport. You have to function as a team. And that includes, everybody that works around you, getting them on board. So that's your number 5. Number 4, this is stuff I went to Davidson College, so I was there when Steph Curry was there. So I love him, and I love the energy that he brings. But when you're on service, I would bring the energy, be the positive influence on your group. You'll be with residents, especially the junior guys. They're getting their butts kicked, and they're tired. They're getting criticized. They're trying to study, and you're there. And what can you do? You can just be positive. Hey, man, I think you're doing a really good job. Keep working hard. I'm happy to help you with any way I can help you. Let's get this done. And it shows attendings and residents that you actually care about learning, that you want to be there, and you want to learn about orthopedics, because ortho is grueling. There are long days and long nights. And if you show up every day with energy, ready to learn, ready to help the team, ready to take care of patients, it's going to really reflect very well on your audition rotation. And listen, you're going to do well in residency if you do that. You're going to do well in fellowship when you do that. You're going to do well as an attending if you do that. And it's not easy to do that every day. But keep that in the back of your mind. When you show up to work, or if you're on call and they call you at 3 a.m, listen, the junior's tired too. So you show up all upset because you're tired and you don't want to do this, and your junior resident's the same way, the senior resident's going to feel the same. So you come in, man, let's go. We got this femur. Let's put it in traction. Let's rock and roll. Let's have fun doing it. And I think it will help you in your audition. Number 3, sit down and be humble. And I put this bullet point here that it's not about you. And what I'm meaning is, when I was on audition, I was so focused on what I did every single day. And I would come home and I'd be like, man, did they even notice me today? They didn't ask me any pimp questions. I didn't have any good learning opportunities. I did this, or I didn't do this, or blah, 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 blah. And I just finally sat back and I was like, dude, it's not about you. It's about, first of all, taking care of people. Secondly, it's about the team. You are the most junior member on your team, and the whole day doesn't revolve around you. And I think and that's mainly from how I felt when I was on audition rotation. I was so focused on what I wanted to do, and I wanted to get noticed, or I wanted to look good, or whatever I needed to do, that I just finally realized, dude, it's not about me. It's about the team. It's about helping people. It's about helping patients and learning. And wow, what a difference it made for me once I finally got that through my head. So hopefully you guys can kind of understand that. Like I said before, being a humble person, is a very good trait. It makes you relatable. It also brings that human element that everybody is not perfect. It also allows you to build relationships with patients, ancillary staff, residents, attendings. That's really important. And lastly, it helps you propel your growth through constructive criticism. Listen, you're not going to be perfect on your audition. You're not going to be perfect as a resident or a fellow or as attending. It's not going to happen. So for you to sit back and be able to be humble enough to admit when you're wrong, accept constructive criticism, is paramount. because that allows you to grow and get better. So number 3 is important. Number 2 is understanding your role. I think you've heard me say that and echo that throughout this lecture so far. What is my role on the team, and how can I improve and help the team get better? And that's important. You are the most junior member on your team. As a 4th-year medical student, you're the junior member. Okay, and for me, what I kind of wanted to do early on in my audition is just establish my role. What did these guys expect, or these girls expect me to do? What do they want me to do? Do they want me to, get to bed, do stuff like that? Because everybody has different expectations for the medical students. I went to one program and I was expected, if I could, to learn how to do intra-articular knee and shoulder injections. And then from that point on, once I showed I was competent, I was flying and doing them. In another one, didn't expect you to do anything. So establishing a role early on is important, because then you can focus on your role and take pride in your work. Your role is not going to be, or your job description is not going to be the most glorified thing. You're not going to be making the incision. You're not going to be doing the surgeries. Obviously, you're med students, but maybe your job is to, get the splint ready for, post-op patients. Man, I would go get that splint, have it ready, have it rocking, ready to roll for the resident. That would be my job, and just take pride in it. It also helps us evaluate you on your ability to work within the team. Because when you're an intern, you have a specific role, and a 2 and a 3 and a 4 and a chief, and so on and so forth. And understanding that role and being able to focus your time and effort on that role is important, and I think it helps you stand out. And lastly, don't forget thank you. Like I said before, you heard me harp on this throughout the entire lecture. Ancillary staff, nurses, medical assistants, radiology techs, not so much residents attending. Sure, just thank everybody for helping you. I'll tell you what, people have taught me things that you would never thought they'd be able to teach me. I mean, I've had radiology techs teach me. I've had, scrub nurses. I've had, bed techs, the people that move the patients on and off the bed for you, making, I wouldn't say minimum wage, but, not making nearly much as your attendings. They teach you, and thank them for that, right? Because they're investing in you. They're teaching you for a reason. And obviously the attendings and the residents are doing the same. So if you had a good experience, if you had someone that really invested in you and kind of mentored you throughout the way, just say thanks. I mean, thanks for helping me. Thanks for teaching me along the way. I learned a lot. If you want to take it a step further and do things like, handwritten thank you cards or emails or texts, that's fine. I don't think it makes or breaks you, but just like I said, it just shows you care. And also don't forget the resident coordinator. Those people put up with a lot. They have to do a lot of work and manage a lot of different people's personalities. So if they've helped you, if they've gone out of their way to get you an audition rotation, do not be mean to them. Be nice to them and thank them, right? Because they have direct access to the program director. And once again, I've seen, resident coordinators, I wouldn't say make or break, but they put their input in. So that's important. Anyone you cross paths with, you'd be very surprised. So just don't forget to say thank you. It's important. And I'll tell you, even to this day, if I have an attending, that's letting me do a lot and let me do cases, that's their patience. I thank them at the end of the case. As they're walking out of the room, thank you, Dr. So-and-so, great case. I still do it, and that's probably habit, and they probably don't even realize it. But, it's their patience, and they're letting you learn on them. So be thankful. So in summary, audition rotations are stressful. It's important that you understand your role on the team, like I said before. Take pride in your work. Remain humble throughout the process. And I'm telling you guys, I think if you do this, you're definitely going to secure a residency in orthopedic surgery. There's no question about it. And lastly, just remember that we're colleagues, and you should be excited that that I'm actually excited that you guys are going to be my colleagues one day. But also, you have a lot of fun when you do it. So I had a lot of fun on my auditions. These aren't pictures from my auditions, but this is a picture here here you go. This is one of our bed techs who's worked at the trauma hospital for over 20 years. We're getting ready for a COVID case. This is John Floyd here. If you guys can see my mouse, he's one of our heads of trauma. He's he's a beast. He's a really good surgeon, really well trained. And there's me. We're getting ready to go do a COVID case together on call. So we're, like I said, this is a fun experience. We're having fun. This is my dog Enzo. He's at the vet. He's a great guy. I love him. He's a Maltipoo. It's a Maltese and a miniature poodle put together. I wanted a golden retriever, but my wife wanted a Maltipoo, so we got a Maltipoo. But he's been fantastic ever since. And then this is my daughter Sienna. This is my wife Katie. Probably wouldn't be thrilled about putting that picture in there with her, but she's 15 months. We are actually doing a cake tasting. We had our wedding delayed for 2 years because of COVID, or no, it was like 18 months or something because of COVID. And we just finally got to do it. So we were doing our cake testing at the hotel, and Sienna was all on board. Great. So this is the end of my lecture. I'm happy to take any questions. I think that is sometimes the most helpful thing throughout the process is just, I'm happy to field any questions that you guys may have. So I'm going to stop sharing my screen. Well, actually, Adam, should I stop the recording first? Or keep it going?
Keep it going. Yeah, keep it. If there's any questions I'll open up the questions. Why not? Yeah. So as you touched on all these major points in your, just as an offshoot, are there any specific knowledge resources you would recommend to prepare?
Yeah, of course. And I was thought about putting that in the lecture, but yes, I think the first thing you guys, it's helpful is the Ortho Bullets is great. I think it's very helpful. Especially if you have, you can even ask the residents what their login information is if they pay for it. That is super helpful to be on Ortho Bullets, to do those questions, to kind of look it up and kind of read. Number one. Number two, the Handbook of Anatomy, Orthopedic Handbook of Anatomy. Actually, they have it on person. But Adam, you know what I'm talking about, right? It's the Netter's Orthopedic Handbook of Anatomy.
Yep.
That is key. I still have mine. I'm looking at my bookshelf now and seeing if I can pull it out and show you guys. But I'm sure everybody is quite familiar with that book. So I'm sorry, I'm looking around to see if I have it available around me. I don't, unfortunately. But yeah, that is the key. That is very good too. So those two resources are really helpful. And then lastly, the Handbook of Fractures. The black Orthopedic Handbook of Fractures is important. It's helpful as well. A lot of the questions come from those resources. So I think if you focus on those three resources, you shouldn't have an issue at all from an orthopedic knowledge base. And like I said before, we do not pick the people that know the most about orthopedic surgery. I'm not discounting that you guys shouldn't be studying and learning, but it is not the end all be all. That is not the end all be all. But those three resources.
Any questions from the audience for Dr. Ritchie?
And I would encourage you guys, if you have questions, fire away. I normally do this. I do this with the VCOM. I'm a VCOM Virginia Tech guy. So I did this with the VCOM guys, and we talked for like an hour and a half. Just to fire them away. So this is from Adam. So what are the basic skills you expect medical students to know during our audition rotation? That is dependent on, so Adam, I would tell you that's dependent. We don't expect you guys to know anything, essentially. We expect you guys to come in, be coachable, meaning that we can teach you, be teachable, and work hard, put the hours in. And the other things we talked about, being nice to people and things like that. That's what we kind of expect you to know. Now, basic skills that I think can help you during your rotation would be if you knew how to suture at all. Any suturing, I think, is helpful because, we'll let you suture for sure. And if you can suture for us and suture, that's very helpful. So I think knowing how to do suture skills, and that's doing things like horizontal mattress, vertical mattress, and simple interrupted suture, doing a running subcuticular suture, and also too, being able to hand tie. So two-handed tie, one-handed ties, and also a deep dermal or subcutaneous suture. That's the deep to superficial, superficial to deep, underneath the skin is helpful. So if you can do any of that, it makes our job easy. Now we teach our students that when they're on service with us, we make it a point to do that. So that's one. Two is ER management. So being able to go in, find a problem, do a basic interview very quickly, do a basic physical exam quickly, and come out and do a quick little presentation to us is also important. Like I said, we don't expect you to know it, and we teach it to you while you're on service with us. But having that basic understanding of going and interviewing a patient, like, what happened, mechanism of injury, so on and so forth, doing an exam, I think it would really help you and set you apart. So other than that, I think those would be the basic skills from medical school. No problem.
Any other questions from the audience for Dr. Ritchie? All right. Well, thank you very much for your oh, we got one popping in right now.
I'm telling you guys, if you guys have questions, I would fire away. I'm telling you, because I know you guys have questions in there, and this is a very good time for me. I'm very open. I'm happy to answer anything you want. Happy to help you. So use the opportunity. So this is from Julia. Is there a best way of thanking someone, or emails or texts too informal? No, absolutely not. I don't think those are too informal at all. I think the best way to do it is just bring up something during that rotation that will remind them of you. So for example, hey, thank you very much for teaching me, so much about the rotation. I really enjoyed your lecture on ankle fractures, specifically Weber B, lateral malleolus fractures. It was a great experience for me, and thank you for, whatever you want to say, for help along the way. That's it. I would try to find something that makes them kind of flip the switch, or have the light bulb go off. Oh yeah, I remember, me and Julia were taking call, and, we did an impromptu lecture at 2 a.m. about hip fractures, and she remembered and she liked it. Wow, that's great. Something like that, something where they can relate to you and understand and go back to that moment of time that I think is important. No problem. You don't have to type out your questions. If you just want to pop on and unmute your mic and just ask, that's fine too.
I'll follow up. So on a rotation, do you think students should generally expect to scrub in on cases, or more stand off to the side, not scrubbed in? What seems to be the norm for expectation?
So it's all depend on the program that you're on, or the program that you're at. So with us, you pay a lot of money to go to medical school. So you should scrub into the cases. Now, we tend to not have, 10 or 15 medical students standing on the back of the room in the OR suite. I don't know if that's the best way to do it, but some people do. So I would say, I would ask your resident, and normally the resident's like, hey man, you're scrubbing. Like they should tell you, they should kind of take that on themselves to say, hey, you're scrubbing this case. Or if you have multiple students on the same rotation, and maybe there's a numbers thing where you maybe have a senior level resident and a junior level resident and a med student, they don't want 2 med students, 2 residents and attending, then alternate. But normally the resident should be helping with you. With us, you plan on scrubbing every single case with us. There's no question about it. That's how we do things. Like I said before, you guys pay a lot of money to go to medical school. So you should scrub the cases. Now there are some cases maybe that they don't last long enough for you. Maybe the position that you're in won't even help you. So like when we do carpal tunnels, we do them in like 5 minutes. So, and that's what the resident do in the case. So it was actually easier for you to not scrub and just stand over my shoulder and look. And we'll tell you, that's how we are. expect to scrub every case, and that's what we say. But I would ask the resident for sure. There are some things where I was on rotation where they were telling you to ask the attending if you can scrub in the room. I mean, I never really believed that. I mean, if for us, it's the resident helps you. So if the resident should handle that for you, in my opinion. But if not, and if there's a resident not there and you want to go scrub a case from attending, say, hey, doc, so-and-so, do you mind if I scrub and help you out? And they're like, oh yeah, we'll take it. Come on, we'll take the hands for sure. But yeah, I would plan on scrubbing the cases unless told otherwise. And also too, getting off of that, you should get your own gown and your own gloves every single time. Have them available. And if you don't feel comfortable opening them because you don't want to break sterile technique, just tell the resident and they'll help you. The last thing we want you to do is break sterile technique and have to change the whole table over. So we're happy to help you with that. That's not an issue at all. But if you feel comfortable opening things, then go ahead. We'll plan on getting your stuff for every case. And if you want to take this step further and get the resident stuff too, that's great too. This is from, all right, hold on, we'll take the first one. What do you expect for students as far as reading radiographs? So we do expect you guys to read radiographs, but we teach you how to do it and how we like doing it. So how we teach our students is the first thing is you want to look at the radiograph, and say what it is. So this is a AP or lateral radiograph of the right wrist, in a skeletally mature patient, demonstrating a intra-articular comminuted distal radius fracture with dorsal angulation and displacement with a concomitant non-styloid. But how we like to do it is you have that formal presentation in the beginning, and then reading the radiograph, and that's just going to take some time and some studying, on how to go about doing that. But that's why you're there. That's why you're on rotation, and the resident should help you through that. If you're going to do a formal presentation to an attending, you should run your reading of the radiograph and your diagnosis all past the resident that's above you. So, for example, we have students present at morning report, but their presentation is we make sure we look at it and we help them along. So when they present to the attending, it sounds really good because we ultimately want you guys to look really good. That's why you're there, especially if you're helping a lot. So as far as reading radiographs, start at the fundamentals. What use, are they skeleton mature or not, of what body part, and then break it down from there. So Adam, again, how important is research with applying? I think it's getting more and more important, especially after everybody's ACGME accredited now. I think research is it going to be make or break you? No. I think it's good to have a couple projects, at least if they're not published, it's fine. At least have something to talk about in your interview about research. Mainly, we want to look at people that care about learning orthopedics and want to kind of further the specialty in whatever way possible. So I think you should have a couple projects on your resume to talk about, and then be very familiar with those projects when you go ahead and interview. Because people are going to ask you about your research, and they want to see if you're going to do research as a resident. And some programs may be more research heavy than others. But I don't think it's the make or break, but I think it's something that you should have on your resume. And if you're on a rotation, we're always happy to help with students with research too. So if you guys want to do some research with us or whatever, we're happy to help you, but you can ask the residents on that too.
And there was one question in the general chat that came through, and that's from Raza. What are the most important classifications we should have down for fracture?
Oh man, so that is a long list, Raja. I would say, common things happen commonly. So I would say from a classification standpoint, hip fractures, Garden classification. So I would just start from the hip down. So hip fracture is definitely Garden classification. Intertrochanteric femur fractures, whether they're stable or unstable. Then going down to, I would say, the tibial plateau and Schatzker classification. Ankle fractures are going to be Loggy-Hansen classification. The calcaneus fractures are the Sanders classification. I don't know if that's pretty complex for them to ask you about that. Hawkins classification is for talus fractures, but that's just lower extremity would probably be important. You know, what I would do when you're on your audition rotation and you have something that comes in on call, or there's a topic of discussion, if they're doing a lecture the next day, look up that classification, and you'll see that common things happen commonly. So you'll just see a lot of hip fractures that you'll need to talk about the Garden classification. You'll see distal radius fractures, and some folks talk about the LaFontaine's classification for distal radius fractures. So it's really hard to sit there and tell you, okay, these 5 ones, if you know these 5 classifications, you have it, because that's just not how it goes, unfortunately. It's all based off of what the topic is that day or the next day, what the surgery is. So if you guys are, if you're scrubbing in on a open reduction internal fixation of a tibial plateau fracture, I would know the Schatzker classification, and I would know what that fracture that you're fixing, what the classification is for that. So is that a Schatzker 1, 2, 3, 4, so on and so forth. So that's how I would kind of approach it instead of just memorizing all these different classifications. That makes sense. Oh, sorry. And also expectations of reading x-rays with classifications. So yeah, so how I would do that is whatever case that is, I would see those radiographs and I would know going into the case what that is on radiograph. So if that's a tibial plateau fracture, and that's a whatever a Schatzker 1, 2, 3, or 4, based off the radiographs, or 5 or 6, whatever it is, I would know that. So I'd be able to apply it to the patient that you're taking care of.
All right. Well, Dr. Ritchie, again, thank you so much for your time on this holiday weekend.
No problem.
To all our participants, again, he put his contact information in the chat. So
yeah, I did. It should be in there. Yeah, no problem. So if there's anybody that wants to email me or call or whatever, I'm happy to help in whatever way possible. Like I said, this is a stressful time for everybody, and I understand that, but you guys will get through it. And at the end of the day, you'll be pretty pumped on match day. It's all worth it. So just go through the grind. Everybody had to do it. But if there's anything that I could do to make your lives easier or less stressful, I'm happy to do that.
Thanks so much. Have a good night, everyone.
All right. Take care. All right, Adam. Take care, man. Thanks again.